So good evening, everyone. My name is Filippo Genovese and I'm the president of the European CMT Federation. And I'm glad to have all of you tonight for our webinar in preparation of the second CMT Specialist Conference. And our host is Davide Pareyson. He's a clinical neurologist working at the Fondazione HMSN Istituto Neurologico Carlo Besta of Milan. Is co-chair of the PNS working group, Peripheral Nerve Disease Working Group of the the European Reference Network. His main interest is clinical research in inherited neurological disorders with special reference to hereditary and acquired peripheral neuropathies and motor neuropathies. He performed a lot of studies on phenotype-genotype correlation, clinical findings, electrophysiology, neuropathology. I mean, his CV is very impressive. It has also published a lot of research in peer-reviewed journals. And we are really glad to have him tonight to present the last breakthrough about CMT research and with a general overview of CMT symptoms and what patients can do to boost research. So Davide, thank you for joining us. The stage is yours.
Thank you very much, Filippo, for this kind introduction and for inviting me to give this to give you this seminar. And I see some noise. Okay. These are my disclosures, and these are the challenges facing patients and researchers in this disease. I will give you an overview of the symptoms and clinical forms and genetic causes of CMT. I will briefly speak about the outcome measures and illustrating the insights from the latest Peripheral Nerve Society meeting in Edinburgh. I will give you an update of what's ongoing from the clinical and preclinical point of view with clinical trials, and I will be ready to answer your question afterwards. CMT and related neuropathies. This is the most frequent hereditary neuromuscular diseases affecting, it's calculated 10 to 28 persons every 100,000 individuals. And in Europe, this means that there may be up to 200,000 affected subjects. And the core clinical presentation is rather characteristic, as we will see, as most of you know. There is considerable variability in disease severity, and there are forms that can differ widely, so this may complicate diagnosis. It is also highly heterogeneous on genetic ground, with more than 130 associated genes, and this is a great challenge for diagnosis. And these are genes that are involved in very different functions in the nerve, in the Schwann cells, in the axons, in the body, but all are important in some way for the peripheral nerves and all lead to CMT and related neuropathies when mutated. Here you can see a representation, schematic representation of the spinal cord, where the origin of the motor nerves take place. Motor nerves goes to the muscle through the neuromuscular junction in the muscles and make it contract. And in the opposite sense, the sensory nerves collect all the sensation from the body, from the skin, from the inner organ, from muscles and joints and so on, and go back to the spinal cord and to the brain, projection to the brain, conducting the sensation to the brain. So when the nerves function like electrical wires with the axons and the myelin, and conducting the impulses across the body, and we have motor and sensory nerves. When there is a dysfunction of both sensory and motor nerve on inherited basis, we speak of hereditary motor and sensory neuropathy. This is the origin of the acronym HMSN that correspond to the common form of CMT, which is by far the most frequent. When only the motor nerves are involved, clinically, electrophysiologically, and at nerve biopsy. We speak of the motor form of CMT, that is the distal hereditary motor neuropathy, and these are much less common. And we may have few sensory forms, or mostly sensory forms that are called hereditary sensory neuropathy, and these are extremely rare and a bit different because of that mostly sensation. And so the overall clinical presentation of CMT is characterized by foot deformities that affect the vast majority of patients, 85 patients in our series. And scoliosis may occur also less commonly. Sometimes frequently is very severe, and more commonly is milder, but affecting 20% of the patient. And what happens is that the disease starts from the longest, the largest nerves. So it starts from the feet, causing wasting and weakness of muscles, and slowly ascend to the leg, to the distal part of the thigh, and to the hands, causing disability, weakness, and also sensory abnormalities. Sometimes the nerves are enlarged and are visible and palpable. For the sensory neuropathies, sometimes they are so severe that causing amputation because sensation is very severely affected. And you see the typical scavus deformities, sometimes very prominent. And overall, most patients show an early onset of disease. The disease runs at very slow chronic course, and there is a set variability of disease expression, severity between families, but also within the same family there may be differences. Inheritance is most commonly direct from one generation to the other, autosomal dominant. Sometimes it travels through the X chromosome, affecting mostly males. In other cases, we see autosomal recessive forms less commonly, and sporadic cases occur sometimes because the mutation occurs de novo in that individual and is absent in relatives. And these are the most challenging cases, and sometimes also the mitochondrial DNA when it may cause CMT-like diseases. Okay. The typical patient has onset of disease within the age of 20, and there is a positive family history of CMT. Sometimes this is not always evident because there may be relatives unaware of being affected or so mildly affected that they are aware, and you need to visit them. Skeletal deformities, as said, are present since the school ages, starting with high arches, also sometimes starting with pes planus, flat foot, that may become later on cavus. Scoliosis may occur, as said, and the child is clumsy in sports, is slower than the mates, has difficulties in running, then start to trips, to sprain ankles, sometimes is walking on tools, and with time there is difficulties in raising the foot. And so the child, the adolescent is seen by the pediatrician, the general practitioner, the orthopedician. These are the most frequently involved specialists at the beginning, and because of pescadus as well, and later on neurologists, child neurologists, and physiatrists are involved. Then with time there is a progressive walking difficulties, and the patient may find difficulties in finding the shoes, and then muscle wasting and weakness involving, as said before, the feet, then the legs and the hands, with difficulties in doing buttons, in performing fine motor movements, in writing, and this is the typical presentation there may be variation in severity, with some mild cases, others more severe. And the part of the patient complained of decreased sensation in the feet, then in the hands. The midterm reflexes usually are decreased to absent, and about 20% of patients needs surgery because of foot deformities. There are, on the other side, cases where the disease has much later onset, sometimes as late as in the 70s, give you an idea of the wide heterogeneity in the presentation of CMT. I have some difficulties in moving. Okay. Other frequent symptoms beyond distal muscle weakness are fatigue, frequent muscle cramps, sometimes pin and needles, the sensation to touch, temperature, pain. Sometimes pain is present because of the skeletal deformities, because of fatigue, or sometimes true neuropathic pain. Most patients complain of, as you know, cold feet, sometimes cold hands, sometimes hand tremor, and there are patients that, because of the temperature with cold, have sort of conduction block and find difficulties in movements. The hand particularly are blocked with cold temperature. So when suspect CMT, this is for patients, for therapy subjects, and for physicians, can be suspected at any age, but often children and adolescents. Young adults are the first signs out this period. For any peripheral neuropathy, the physician should think of the possibility of genetic form. Family history is relevant for diagnosis, but sometimes it's absent. And for deformities and tripping falls are clues and red flags for CMT, and also signs and symptoms starting from the feet and hands. The distal predominance is typical of CMT, and also slowly progressive course. So the diagnosis is based on the clinical presentation, on the family history, and the physician must understand the pattern of inheritance. Then conduction studies are important, although they do not need to be performed every year. They are important for the understanding the type of CMT, and then if there is any worsening, it may be helpful, but not too frequently, also because there are other signs you will know. Then you have, you need to understand if there is a conduction slowing, if there is demyelination, or the neuropathy is more axonal or intermediate. Is it sensory and motor? Is it pure motor? Is it pure sensory? So this is important to classify the type of CMT, and then this is useful for addressing properly the genetic testing that are now widely available. Sometimes other investigations are needed, sometimes lumbar puncture, particularly for differentiating from inflammatory neuropathies, and also sometimes the biopsy need to be useful. So classification is into demyelinating axonal type of CMT, demyelinating autosomal dominant CMT1, demyelinating autosomal recessive CMT4, axonal is CMT2, mostly autosomal dominant, but also recessive forms are unknown. So the kind of inheritance is important. There are intermediate forms between the two types with a slowing of conduction that is milder than the type, but more evident than the axonal type, where the conduction velocities are usually preserved. Then you have the pure motor forms or the pure sensory forms with some overlap, and you need to differentiate from other genetic diseases or acquired diseases, like the hereditary spastic paraplegia, the autoimmune diseases, the myopathies, and that are important for the differential diagnosis. Then you see how many are the genes associated with the different types of CMT. This is becoming quite complicated, and this is still an incomplete list of genes. And those in red are the most frequently mutated, and SORD is an important one because it seems to be also quite frequent among the last identified. And you see there are different types of CMT1, the autosomal dominant demyelinating, several types indicated with the letters. CMT2 is we have exhausted, we have no more letters, and we have from A to Z, CMT to Z, so we need double letters here, so it's becoming very complicated, the classification even for us. And these are the demyelinating varieties from A to A to J, the intermediate dominant, intermediate recessive, and the X-linked type, and the motor recessive. So it's only to give you an idea of how it's complicated, and we need to move with caution, and need to be very well addressed, otherwise we risk to miss the diagnosis, to make the proper diagnosis. So we have a practical approach to diagnosis. We defined the clinical presentation, the inheritance patterns as shown before, the nerve conduction studies. Then we ask for the molecular tests, depending on which country you are, the availability of a single gene testing or so-called next generation sequencing. You may have panels where with one shot you can test all the CMT associated genes, or the whole exome sequencing, which is more complicated, examining all the existing genes beyond the CMT. And recently, still for research, whole genome sequencing. That means that you sequence the whole chromosomes, all genes, all regulatory sequences, and so on. So it's very, very complicated. And so these are all costly. The cost is going down. The possibility of the lab is becoming better, but there is still queuing in performing this testing. But there is it's becoming more easy to have this diagnosis. If you're lucky with the panel or with the West, or sometimes with the genome, you pick up a known mutation in the known gene that is known to be associated with CMT. In this case, you have the definitive diagnosis, and this is for certain. In other cases, you find no mutation at all. This happens, and panels after the most frequently genes have been excluded still reach the diagnosis in 20 to 40% of the cases. So we have still a proportion of undiagnosed CMT. We'll see later. And the most troublesome problem is when you have so-called variant of unknown significance. That means that you find in some gene, maybe in a gene associated with CMT, a variant that you do not know if it's the cause of the disease or not, because it may be present in some other individuals that are not affected. And so you need to interpret with care these findings, because you risk to make a wrong diagnosis. Not all variants are disease causative. So in these cases, you need to see the frequency in the population variant, if it travel within the family with the disease, if the site of the mutation is conserved across different species, which is the mutation type. There are programs, computerized programs, to analyze the consequences of the mutation, and so on. So we have a number of tools to try to understand whether the behavior of this variant is associated with the disease or a casual type. And then we need to go back to the phenotype to understand whether this is compatible with the disease. So it's not an easy task. You have much more possibilities of diagnosis, much more than in the past, many more, but this is becoming more complicated. And here just to say that there are other sometimes associated findings beyond CMT that may be useful for addressing the diagnosis and that may complicate sometimes the CMT, like visual findings or scapular winging or upper limb predominance and so on. This is the rate of diagnosis in London, which is probably the most advanced center in the world for diagnosis because they have a large series of patients tested with different tools, including recently the genome. In spite of all the tools, there is still a percentage of patients and 30 subjects with CMT that cannot have the diagnosis. 1/4, even in London, is not still undiagnosed. This is particularly for the axonal type, for the pure motor and sensory forms, and more commonly, less commonly reached genetic diagnosis. And we are now investigating why it happens, and there are evidences that this may involve other type of mutations rather than point mutations or small mutations. There may be complex rearrangements, the so-called structural variants. That means that large pieces of chromosomes are wrong in some way, and this may cause CMT. In other cases, there are pseudogenes. What does it mean? That, for instance, in sorbitol dehydrogenase, we have a very similar gene that is called SOR2 that is not translated into protein. It's there for some reasons. We do not know why, probably an ancient reason in the DNA, but it complicates the diagnosis because the sequencing does not distinguish well between the important gene and the pseudogene. And this is the cause why it was undetected until 5 years ago. There may be repeat expansion, that means repeat or small fragments or nucleotides of letters of the DNA that are repeated many times in the portion of the gene that is not translated. And you can easily miss these repeated sequences, for instance, in canvas, which is a very frequent type of genetic sensory neuropathy of the middle to late age. And you need a special reading, the so-called long read sequencing of DNA. This is not the usual way you examine DNA, a very advanced tool. So it's available only in a few centers. It's become quite complicated. So with these novel techniques, we can better investigate DNA, understand why we do not have diagnosis in some cases. For instance, there are two types of CMT that are related to large insertion DNA that cannot be seen with the usual DNA analysis. So quickly, the differential diagnosis it's with other hereditary neuropathies, with acquired neuropathies, mainly autoimmune, distal myopathy, and other diseases, as said before. And this is the part of diagnosis, symptoms, and so on. Then I move quickly to the specific after major session, and Mike Shai made an excellent, very nice presentation at the PNS meeting, showing what has been done during the last years to improve other way of measuring the disease progression and therefore the response to therapies. This is a real challenge because the disease is slowly progressive. This is good for affected subjects, but it's a problem for us if we need to measure, as we have to measure the disease progression, and the response to therapy is quite complicated. And many of these outcome measures have been developed through the Inherited Neuropathy Consortium led by Mike Shine and with the collaboration of several centers, including mine. And this is the list of clinical scale that are specific for CMT according to age mostly. This is the CMT examination score, or CMT neuropathy score. Most of us use the routine of CMT evaluation, and I will will quickly show all of these measures. Then we have more complicated scales with some advantages that I will show you. For the pediatric scale developed by Josh Burns and colleagues, one is developed for infant scale with children between the age of 0 and 3 years. From the CMT PETs, we have developed a scale specific for adult patients, the so-called CMT functional outcome measures. Then there are two scales for collecting from the patient their perspective, the so-called patient-reported outcome measures. And this relates to the ability of the affected subject to perform a series of activity of the daily life. And this is specific for children. Then we have the need for surrogate biomarkers, so-called clinical biomarkers, and I will briefly speak about imaging, the blood biomarkers. There are a lot now, and also skin biopsy biomarkers, the little skin biopsy, and in the States, John Sparring is able to analyze the expression of different genes that may be important for understanding the disease and the clinical progression and response to therapy. So very quickly, okay, this is the CMT neuropathy score, CMT examination score, based on symptoms, motor and sensory in the upper lower limbs, on also the clinical findings during the visit, again sensory and motor in the upper and lower limbs, and two items facultative for physiology. And this is very fast, widespread use, but is not responsive. It does not change much over time, so it cannot be used for measuring response to therapy. This is the pediatric scale. I show you the advantage is that it's a composite with different measures. All are normalized towards children of the same age, normal children. So the score is linear, is adequate for the age. You know, children grow, so their ability to perform these different tasks change, and we need to have a comparison. And it's quite responsive. That is good. It's long to administer, so it's reserved to clinical trials mostly. Then we have the infant scale, which is very much like the CMT PETs with limited action able to be accomplished by infants. And we are studying the responsiveness. This is the scale for adult patients that requires, again, on the model of the CMT PETs, with different components, strength in upper limbs, in lower limbs, and dexterity performing tasks, rising a stair of 4 steps, walking or running for 10 meters, standing from a bench, and balance ability, and ability to raise from a chair, walk for 3 meters and going back to the chair, the 6-minute walking test. All this again are normalized to normal patients, and we have a score. We are testing the responsiveness. Again, it's rather long to administer, but it's linear, normalized, and it shows rather little changes in CMT1A. So it's, we need to understand whether it can be used for clinical trials. This is the patient-reported outcome I told you. different questions answered by the affected subjects, giving an idea of how difficulties in action in daily life. Again, responsiveness is under evaluation gives you an idea of the disease burden, and this has been translated in other languages beyond English. It did show some change in the symptom. And the last, the pediatric quality of life scale being tested during responsiveness. So we have different measures with different ability to respond to change over time, the natural evolution of the disease, and the ability of show a response to effective therapy. All the clinical ones have a severe limitation. They are not very responsive, important, but not responsive as we would like. So we need to have also surrogate endpoints, paraclinical biomarkers. And the most important is the quantitative magnetic resonance imaging of the muscles. They measure with these special sequences, we measure the fraction of the muscle that is substituted by fat because of the denervation process, because of the loss of axons. When you lose an axon, the muscle becomes denervated. Partly the other axons compensate, partly some fibers are lost and are substituted by fat. And you can measure the progression of fat substitution quite well over time. So this is the most responsive outcome measure we have for CMT. And time-consuming, costly, but needs standardization. But this is a very important tool we have, although it is not accepted as a primary endpoint in clinical trial. We cannot use still only MRI to understand whether drug is functioning in the clinical trial. We need to use other measures. And these are the list of biomarkers in the blood that are being tested. And the most effective until now is the neurofilament light chain that shows some increase in CMT patients. And I mean, it's useful to follow the trajectory of patients and to see whether a trial can be effective in the future. And there are several others on the study. Then the third challenge is research. And the last part of my talk will be devoted to this task that maybe is the most interesting for you. Starting from the disease, we have now several cellular models, animal models, and also now the possibility of using patient-derived cells that from fibroblast cells from the blood, you can obtain stem cells, and you can differentiate those cells into motor neurons, into muscle, with some difficulties into Schwann cells, and also have organoids that is nervating muscle. So our ability to reproduce models starting from patient material is improving. This is also a very important tool. And this is changing also the situation from we better understand the pathomechanism of the different CMT types, and we are more able to develop targeted therapies. So there are still a lot of challenges in the way to a therapy, but we are seeing the light at the end of the tunnel. There have been many advances in the field. There are trials ongoing, others in preparation. There are many treatments in the pipeline. And so I will briefly speak about gene therapy in sizing, and I will focus on some pharmacological drugs with some trials giving you an update. We wrote, and also Cleopas group wrote several nice papers summarizing the situation of the therapeutic approach for CMT. And this image from our papers summarize the several approaches that are under study for the different types of CMT. So this is a comprehensive figure with good numbers of attempts ongoing or understanding. So this is encouraging. And I will first focus on gene therapy and silencing. Still theoretical from some points of view, but with a couple of clinical trials under finished or under evaluation. Here the approach depends very much on the type of gene dysfunction. For instance, CMT1A, where there is an increase in PMP22 expression, the aim is to reduce the expression of PMP22. There are several approaches here with different antisense oligonucleotide, small interfering RNA, and different approach gene editing. So you see how many have been tested in animal models. They were effective in animal models from different points of view, and some are reaching the clinical phase and they will be tested in not far future. And the issue is difficulties are targeting properly the Schwann cells and for a lifelong not a severe disease, there are issues of cost risk benefit. We need to avoid to cause downregulation excessive of PMP22. It is associated with the another neuropathy, but all these issues are being addressed. Then we have the dominant mutations. We can address either theoretically and in animal models by gene editing. Selective gene editing still not possible in patients, but is a study in models. Another approach is to overwhelm the mutated allele, for instance, in CMT2A caused by mutations in mitochondrial 2. An approach could be to increase mitochondrial 1, which has very much similar function, and that could substitute mitochondrial 2 in the nerves. And there are studies undergoing on CMT2A with different approaches of gene editing or increasing gene expression. So the approach to increase the expression of the useful gene. Then we have the introduction of new gene, the so-called gene replacement for recessive disease, where there is a complete loss of function of the genes. You try to insert or replace the defective gene, and there are also attempts to insert a useful gene in other type of CMT. Here we have studies in the animal models, but some clinical trials as well. So gene replacement is also done for other diseases, particularly for muscle diseases. There are trials ongoing. Here, the difficulties is using what brings the gene to the correct place, the muscle for muscle diseases, to the nerve for nerve diseases, and so on. So it's an issue. We use vectors. Now the most used are adeno-associated viral vectors, and that where there is an envelope and the gene is contained in this envelope. The other problem is how to deliver this envelope and the gene to the correct place where they must be expressed, that is the peripheral nerve, the Schwann cells, or the neurons. And now different approaches have been tested. Now the intrathecal approach, so with the lumbar puncture, is the most popular at the moment, the most effective at the moment. And there are issues of possible adverse events, maybe neurological, with neurological reactions that have occurred in patient with muscle diseases, reaction to the viral envelope or to the new gene, and this is something that needs to be addressed to improve that safety. But there are clinical trials. One has been completed for a neuropathy, hereditary neuropathy, that is giant axonal neuropathy, that is usually more severe than CMT, although the milder form may resemble CMT. 40 patients have been treated, and with the intrathecal delivery of the defective gene, and there were some adverse events, but also some evidence of possible benefits in motor function scores and other outcomes. So we have on one side problems of adverse events, on the other evidence that the gene reaches the target and exerts some good action. Another trial for a smart one that is allelic, that is caused by the same gene as a type of axonal CMT, that is CMT2S, this is the gene involved. A trial in the United States has been designed with a vector developed in Italy, and with a single intrathecal injection, again with number puncture with the defective gene. But again, this has been stopped for different reasons. So there are attempts also with other gene insertions, but the pathway is still not. This is to give you an idea. Then let's move to the pharmacological effects. Here for CMT1, there are several approaches possible in study. And let's focus on PXT3003 that many of you know, developed by a French company. It's a compound made up of 3 compounds: oral baclofen, naltrexone, and sorbitol. Sorbitol is a sugar. Naltrexone is an antagonist of an opioid. Baclofen is used in clinical practice to decrease the muscle tone. And there have been trials with encouraging results, including a phase 3 trial that needed to be repeated because there was a problem with crystallization of the high dose of compound. In this first phase 3 trial, there were encouraging results that, however, were not reproduced in the novel phase 3 trial. So eventually the trial was considered to be negative. The French company has dismissed the idea of continuing. However, there is another trial completed almost completed in China, and we are waiting for results to understand how this compound is effective or not. There are issues about the responsiveness of the measure used, and also some concern that sorbitol might be detrimental to the nerve, as you will see in another form of CMT. And then I want to focus on the CMT-SORM, that is the most frequent recessive type of CMT, axonal or pure motor type. About 10% of recessive CMT are probably linked to this mutation in this gene, and that is encoding sorbitol dehydrogenase, that is converting along this pathway the sorbitol to fructose. And because of this enzyme doesn't function, there is a remarkable increase in sorbitol in blood and urine, and also in the nerve. And this is the reason why probably the nerve doesn't function well. There is a neuropathy. And here the approach is to act on the preceding step. Aldose reductase is the enzyme converting glucose to sorbitol. If we stop this enzyme, we reduce the accumulation of sorbitol, and the glucose goes in other metabolic pathways. And so a trial was developed because there is a new drug addressing inhibiting aldose reductase. There are other drugs used once upon a time in diabetes, but they are too toxic for the liver. And now this new one is much better tolerated. So a trial was developed and performed in the USA, UK, Italy, and the Czech Republic. And the approach is, again, the CMT sword, because of this sorbitol dehydrogenase dysfunction. The sorbitol is very much increased in the blood during the nerve. The idea is to stop the action or reduce the action of aldosterone phase, which should reduce sorbitol. This has been proven in animal models, in patient fluid, and so the trial was performed, and an interim analysis after 1 year showed more than half reduction as a mean of sorbitol of the blood. This reduction correlated with clinical data that is that there is a correlation between the change in sorbitol and change in clinical measure, although no change was significant at 1 year, but the CMT health index, that is the patient-reported outcome addressing the disease burden. And also, the MRI decreased in progression in year 2, the second year, so this is also very much encouraging, and it was also very well tolerated. So what's next? And because it's not enough to prove beyond any doubt that this treatment is functioning in CMT sword, but the evidence rational and the first results are very encouraging. So there's a discussion between the company with the FDA, and they are discussing the possibility of having a conditional approval, but only in the US. That means in any case that there is need for a confirmatory trial, phase 3 trial, that confirm the clinical benefit of the drug. So this trial is under preparation. It will have clinical and MRI measures. It will be conducted in Europe and US, and should start in early next year. And we will keep the CMT world updated on this. Then I'm going to conclude. This is another interesting compound, NMB 678. It's being tested in CMT because we know that there are defects in the neuromuscular junction in CMT, that is the communication between the nerve and the muscle. This compound inhibits this channel of the chloride ion in the muscle, and is specific to the muscle. So the inhibition of this chloride channel amplifies the muscle response to weak signals, so improves the transmission between the nerve and the muscle. And so a phase 2A study is ongoing in patients with CMT type 1 and 2 with genetically defined forms, and is undergoing in US and Europe with the compound used for 3 weeks because the action is deemed to be quite rapid by improving the neuromuscular transmission. So it's a symptomatic therapy. It is not causal therapy. It does not change the reason for having CMT, but the aim is to test whether it improves the symptoms. So in 3 weeks, in 80 other patients with any genetically confirmed CMT1, CMT2 subtype, is being tested versus placebo. And it's being tested also in myasthenia gravis and spinal muscular atrophy type 3. And there are other interesting compounds under evaluation, the testing the podoprotein response, the neuroregulating pathway that is involved in regulation of thickness of the myelin, in the HDAC6 inhibitors that and be shown to improve the axonal transport and possibly they have an action on the cellular stress and also on myelin. So particularly this compound is potentially useful for different types of CMT. And again, a clinical trial on CMT1A, where it has been shown to be effective in the animal models, is being prepared. So you see that there are several approaches possible. This one is one ongoing in the UK for a rare sensory type of neuropathy that is a metabolic disease, and by providing serine with the oral route, the idea is to overcome this defect caused by mutation resulting in toxic compounds. The idea is to have this pathway, correct pathway functioning again. And this is a trial ongoing with the UK. And so this is final slide summarizing all the possible trials under preparation or ongoing. Again, treatment for mutations. This is a channel. There is an antagonist of this channel that is producing interesting results. So you see how many different approaches are in the study. And I want to end by thanking all the people in my institute working on this, adult patient, pediatric patient, genetics, neurophysiology, and so on, skin biopsy, and all the centers in Italy, all the association, the international one, PNS, MTR, Hereditary Consortium, but particularly and also the RN patients with the European CMT Federation, the Italian HMSN, and the newly born ECRA, the alliance between patient researchers and clinicians. Thank you very much for your attention. Don't forget the meeting, second European CMT Specialist Conference in next October in Naples, and do come. Thank you very much for your attention.
Thank you a lot, Davide, for this clear overview of what's going on in the CMT field. Just let me make 3 comments. One is for the diagnosis, which, as you highlighted, is really tricky because of all of this gene that, from one hand, are good news because we are getting more and more familiar with different genes and mutations involved in a sort of form of CMT. But on the other hand, it makes it really, really tricky to get a diagnosis, especially for the rare forms. The second comment is about outcome measures, and thank you for talking about this as well, because we might be in a case where we do have an effective drug, but we are not able to prove to the regulatory agencies that it is so. So it's definitely something we have to take into account. And a third comment about the therapies, because as you stated, there are a lot of let's call them cross-form treatments that might be the so-called symptomatic treatments that might be the way to go, in the sense that if we think about treating all the genes and all the mutations within the same gene with gene therapy might be tricky. So there are options, of course, for the common forms, but it's definitely hard. But we're getting there. I mean, we are all optimistic. So thank you for transmitting this, delivering this message to us. There's a hand raised by our vice president of ECRA, and vice president of European CMT Federation, president of ECRA, Ingo. So you would like to say hello and switch on your microphone?
Yes, hello. I'm so grateful. Thank you very much for this very, very clear introduction on a very, very complex matter. And the 130 different genes involved in many types. It's I think to attack that and go ahead in research is a huge challenge. And we need, I think, 1,000 researchers doing a common research effort to come closer to our aim to have a cure for CMT. And what is a cure for CMT? It's a cure for hundreds of diseases, in fact. And I don't see how to progress, really. But I have two questions. The first one is very simple. The second one, perhaps less simple. The first one, we had another talk on CMT, and then the doctor or the teacher or whatever, the speaker, yes, thank you, said, just look at your hands, and I can tell you, you have CMT or not. So is this true? What I mean, if you look at my hand, you can see there are certain lacks of muscles, etc. And but is this common to many or all the CMT patients, or is it only one form of symptom which you can have or will not have? So this is for the diagnosis, and for the problem we have really that so many people who have CMT and don't know, and doctors, the pediatricians, or even the doctors who deal with your legs and your.
Yeah. The question is clear in both.
So difficult to discover.
I will answer to this first question, then we go to the second. The first, I mean, the hand, your hand is clearly a possible CMT hand, but can be any type of neuropathy affecting the motor fibers can result in such hand. It depends how long is the history, how long did it take to come to this, is there a family history? So it's a clue, but it's not specific. Okay. On the other hand, there are forms of CMT that affects mainly the lower limbs, and for a long time your hands will be normal or almost normal. And so, particularly for the axonal types, there may be some differences between upper and lower limbs. So it's true generically, but there are not specific and can be different. So okay. It's the foot is very specific because high arches, pes cavus indicates early onset neuropathy, and this is many cases due to an inherited neuropathy. But if inflammatory neuropathy starts very early in life, it can give rise to a pes cavus as well. So again, it's very suggestive of, but it needs to be interpreted with general situation.
Mm-hmm. Thank you. May I ask the second question, which is shorter? You talked about gene replacement, and then you took the term a new gene will be implanted into the body. What is a new gene? Can you create a gene? Yeah. Is it artificial, or is it a gene from other person or from yourself? What is it?
Point. Yeah, it's a normal gene created in the laboratory and inserted in the envelope. The problem is that the affected subjects have already a gene, but it's defective. So it completely disrupted and it's not synthesized, it's not translated, or it's translated in a wrong way, so it's not functioning. So you give the right gene, hopefully in the right place, to replace the defective gene. This is theoretically possible. There are still a lot of difficulties to be overcome. Particularly, I mean, it's being tested for several diseases, but there are more severe than CMT. That's the point. Duchenne muscular dystrophy, for instance, or severe muscular dystrophies, and even CMT type CMT2S is a severe type.
Mm. Okay, thank you.
Thank you, Igor.
Thanks a lot, Davide. And now I'm going through the question we got from the patient's registration form. And yeah, I will just keep those which are related to a specific form related to therapies, because Dr. Pareyson already presented all the option. And I will focus on, for instance, for CMT, but I mean, it would work for any CMT type. Are there any options to slow the progression of the disease?
That's our aim. I mean, while waiting for specific therapies, what we advise always is to perform physical activity, because it has been shown quite clearly that physiotherapy, muscle strengthening is important and improve the performance of the patient. And the mild to moderate exercise is useful. Strenuous exercise is still unknown, and some evidence say it can be done. In other cases, the possibility that is detrimental. So mild to moderate is good, strenuous we do not. And okay. Also we advise to perform stretch, postural exercise, balance, and so on. We know it's useful. It needs to be repeated because we know that particularly in adult patients, the effect does not last for a long time. So repeated or chronic physiotherapy is important.
Yeah, perhaps even avoiding gaining weight.
Absolutely, yes. And this is difficult because CMT patients are more sedentary because of many reasons that are perfectly understandable. My suggestion is always it's difficult to lose weight only with the diet, but it's easier doing performing exercise. I know it's difficult for CMT patients, but every day a little bit is maybe what you need. It's important.
Yeah. Then there was a question specific for HMPP, a clinical study involving rapamycin. Does it sound familiar to you?
Yeah, rapamycin is an interesting compound, but for many reasons, but has an action that can be useful for neuropathies, but is toxic. I would not. I mean, there is no, to my knowledge, no clinical trial in humans foreseen with rapamycin. Maybe niacin. Niacin is another.
Okay, thank you.
Yeah.
Now switching to diagnosis, is CIDP misdiagnosis an issue?
Yes, it is. It is because the relative frequency of both diseases, CIDP is not so rare, and we may have difficulties in making the differential diagnosis on clinical grounds, because sometimes, I mean, CIDP may be slowly progressive, like CMT, the demyelinated type, because both diseases affect myelin. So you have slow nerve conduction velocities, and the manifestation, clinical manifestation may be similar if the evolution is slowly progressive, or there are sometimes cases where CMT has a sudden worsening or fluctuating course in the pattern. And another issue is that nerve conduction velocities usually in CMT1A are homogeneously slowed in all nerves in the same way, in all segments, whereas in CIDP there are conduction blocks, differences, asymmetries, and I mean, the temporal dispersion that are issues, technical issues of who performs neuroconduction. There are types of CMT that mimics CIDP because they are not homogeneous. This is another reason for misdiagnosis. So it is an issue. And in many meetings now we deal with in teaching or in discussing with this.
Yeah, that's pretty important. So another nice question is, how should I prepare for my first neurological consultation? Which questions should I ask to my neurologists?
The first issue is tell your story as you feel it. Tell your symptoms. This is always useful, and the physician should always listen to the symptoms reported by the affected subject, because this is the main basis for diagnosis. The second point is try to choose an expert in the field, because we are working on diffusing, disseminate knowledge. You with the patient association and us as a clinician, so researchers try to disseminate knowledge about CMT, but they are still underdiagnosed, under-recognized, and so.
Yeah, definitely.
So my
yeah, thank you, I appreciate it. I mean, it might be. I mean, we are definitely not prepared for that, and I would stress that sometimes it happens in some countries, unfortunately in Italy, but I'm aware that happens quite often, that you get your genetic testing with those weird gene names and figures, but they do not explain you what those figures mean. So sometimes we don't know what to expect when we go to our neurologist.
Yes, this is also, I mean, what I was saying before, the diagnosis is becoming easier genetically, but more complicated. You need to interpret the results, and I recommend to go, I mean, there must be a communication between the lab and the neurologist and the physician to explain, to discuss between them, because the geneticist needs to know the clinical presentation, and vice versa, the clinician needs to know the meaning of what has been found. So this is, I've seen misinterpretation of the results, and
yeah,
they happen to have wrong diagnosis, so not to understand where the meaning. And
yeah,
sometimes
definitely.
we do not know the meaning. I mean, if you find a new mutation, difficult to say how it will impact in the future. This is also difficult.
Yeah, definitely. Well, then there was a patient with which was diagnosed with HMSN type 1. He experienced sudden drops in strength that recover slowly, and he's asking whether are those flare-ups normal.
They are not normal. We have seen patients sometimes with this kind of sudden deterioration and subsequent recovery, usually. One interpretation is that the genetic neuropathy triggers an autoimmune phenomenon, and this is likely. And sometimes we have treated those patients with IVIG, immunoglobulin, intravenously, or steroids. Some respond, some do not respond. This is the clear overlap between CIDP and CMT1, and sometimes they may coexist in the sense that we believe that the genetic neuropathies facilitate the occurrence of some autoimmune phenomena.
Thank you, Davide. A question about inheritance. So this patient has CMT1A. His father has it. One of his daughters has it, and now his grandson, 13, has a confirmed diagnosis, and is asking whether is there any evidence that inheritance can simply stop.
You must, it's a statistical issue in the sense that every, I mean, if you have CMT1A, every child you have has 1/2 probability to inherit the mutation. And so 50%. It's a casualty. It depends on which chromosome the one with the duplication of the other one goes to the reaching the gamete and the new life and the spermatogenesis on the oocyte of the mother, just by chance.
Yeah, it's like flipping a coin.
The coin, yes, exactly.
Yeah.
And every time is the same probability.
Yeah, if I might add something, do not forget about prenatal. Yeah, prenatal genetic testing. I mean, there are some options out there. If you want to have a baby, then you can select the embryo with, let's say, the healthy chromosome.
Yes, thank you, Filippo. This is the important point. Now it's possible in several countries, now also in Italy, to have pre-implantation assisted.
Yeah, thank you.
Yeah, and you can select the embryos.
Yeah. There was another question about bone complication. A patient with CMT-A and experienced a tibial fracture after ankle fusion surgery, and is asking whether this happens often.
No, it does not happen. So what may happen is that if your ankle is weak and your ankle sprain, you may have a fracture of the foot bones, particularly the fifth metatarsal, the one in the external part, may have a fracture. But I must say I've never seen a spontaneous fracture after surgery. But it's true that when you block the ankle, there is a new equilibrium of your body that may change the stability and the forces, and this might be one reason.
Yeah, totally agree. So the last question from the registration form is a really nice one. So what can we do, patient, to support for supporting ongoing research and help with clinical trial recruitment?
Okay, you are already helping us a lot, because I must say that in CMT particularly there is a strong alliance between clinicians, researchers, and CMT Association, and you've done a great job in having such association now at the European level, and funding ECRA is something that is extraordinary. And we are very much helped by this support. Also, we know that we count on you for recruiting patients in the clinical trials, and for any type of study we are doing, we tell you so that we know that you are supporting us, and also in raising money. One issue is that CMT is partly neglected. It's very frequent, but it's not popular as Parkinson's disease, Alzheimer's disease, because they are more impactful, ALS. So a lot of money for research goes there, and much less is going into the CMT field. So this is something that we need your pressure towards authorities, and also particularly for clinical trials. I was thinking before, you need to press to have the FDA and the EMA accepting the idea that a co-primary endpoint in the clinical trial is MRI, because this is a way to demonstrate that the drug is effective. Otherwise, we risk to wait for years.
Yeah,
that's an issue.
Yeah, we are, as a European CMT Federation, and even nationally, we are advocating for that, because as I said, it would be a pity to have a drug that works and missing the mean to prove it.
Yeah,
so
yeah, absolutely. Yeah.
So there's now a question from the chat. Dr. Michael Chen is asking whether you have any opinion on ibetanone as a treatment for CMT2A related optic neuropathy.
I have no personal experience. Ibetanone has been used for mitochondrial optic atrophy, optic neuropathy, and it's indeed active on mitochondrial metabolism. Although I must say that the effect was not impressive for hereditary attacks as well, and for mitochondrial. Now there are more effective trials ongoing. I have no personal experience. It may be a chance, but there is no trial, no reports as far as I know. Maybe there are isolated, but I'm not aware of. It's not a wrong idea, but I'm not sure it's would be very.
Yeah, there was a person that does have CMT2S. He is asking that she noticed that the trials had stopped in America. I was just wondering why. I don't know which trial is she talking about. Maybe Vanda Pharmaceuticals.
Yeah, I'm not sure because I was said this by Stefania Corti in Milan, who was leading the team who had been developing the vector, and the fear is that the company is not interested anymore. But I have not. I'm not sure they have completely stopped. They were treating children. Because CMT2S may have different severities. We have now adults with milder forms. But yes, it's a pity. One issue is that some of these forms are so rare that companies have troubles in continuing research on this.
Yeah, what I know that because this approach involves using an antisense oligonucleotides, then it's really tailored and focused on a specific patient with a specific form. So they are going step by step.
And this is another approach, yes, going step by step.
Yeah. All right. If there are no more questions from the audience, we thank a lot Davide for his time and his precious information. And thank you for joining us. Let me just share you a slide about save the date.
Maybe some other questions?
Are there?
I don't see the chat.
Yeah, I haven't seen any more questions. Just give you this announcement. We will have 2 webinars, one in September 22nd with Dr. Jonathan De Winter. He will present us the major breakthroughs presented during the last PNS annual meeting. And then on the 14th of November, we will have Professor Vincent Timmerman. He will make a wrap-up of the second CMT Specialist Conference. So it will present you the results and conclusion of that conference. Let me head back to the team. Let's double check. There is a question about the COVID vaccination. CMT2 redness on my feet. She's asking whether other people are experiencing this, but might be too personal, I guess.
Yes, probably yes. Redness of the feet is may occur in CMT because of altered innervation of the small vessel, and I've not seen convincingly deterioration after COVID or COVID vaccination with very few instances. Yeah.
All right. Thank you, everyone, for joining, and have a nice evening, and hope to see you to our next webinar. Take care.
Thank you all. Thank you all. Bye-bye.
Goodbye.